Hello everybody. Welcome to Number 1 Doctor channel. Today video is about common adult orthopedic injuries, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel Number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about common adult orthopedic injuries. X-rays for suspected fractures should always include two views at 90 to one another and always include the joints above and below the broken bone. If the mechanism of injury suggests it, other X-rays should be taken of the bones that are in the line of force, which might also be broken. For instance, the lumbar spine when somebody falls from a height and lands on and breaks his feet. As a general rule, broken bones that are not badly displaced or angulated or that can be satisfactorily aligned by external manipulation can be immobilized in a cast-closed reduction. Broken bones that are severely displaced or angulated or that cannot be aligned easily require surgical intervention to reduce and fix the fracture. Open reduction and internal fixation. Clavicular fractures are typically at the junction of middle and distal thirds. The traditional treatment is a figure-of-8 device that, by pulling back on both shoulders, aligns the bone. Wearing a sling is more comfortable and also works well. If a very precise outcome is desired for cosmetic reasons, open reduction and internal fixation can be done. Anterior dislocation of the shoulder is by far the most common shoulder dislocation. Patients hold the arm close to their body but rotate it outward as if they were going to shake hands. There may be numbness in a small area over the deltoid, from stretching of the axillary nerve. AP and lateral rays are diagnostic. Some patients develop recurrent dislocations with minimal trauma. Posterior shoulder dislocation is rare and occurs after massive uncoordinated muscle contractions, such as epileptic seizure or electrical burn. The arm is held in the usual protective position close to the body, internally rotated. Regular X-rays can easily miss it. Axillary views or scapular lateral views are needed. Collis fracture results from fall on an outstretched hand, often in old osteoporotic women. The deformed and painful wrist looks like a dinner fork. The main lesion is a dorsally displaced, dorsally angulated fracture of the distal radius. Treat with close reduction and long arm cast. Montage fracture results from direct blow to the ulna, such as on a raised protective arm hit by a nightstick. There is diaphyseal fracture of the proximal ulna, with anterior dislocation of the radial head. Galeazzi fracture is the mirror image of the previous one. The distal third of the radius gets the direct blow and has the fracture, and there is dorsal dislocation of the distal radio-ulnar joint. In both of these, the broken bone often requires open reduction and internal fixation, whereas the dislocated one is typically handled with closed reduction. Fracture of the scaphoid carpal navicular affects a young adult who falls on an outstretched hand. Patient complains of wrist pain. Physical exam shows localized tenderness to palpation over the anatomic snuff box. In undisplaced fractures, X-rays are usually negative, but thumb spica cast is indicated just with the history and physical findings. X-rays will show the fracture 3 weeks later. If original X-rays show displaced and angulated fracture, open reduction and internal fixation are needed. Scaphoid fractures are notorious for a very high rate of non-union. Metacarpal neck fractures, typically the fourth or fifth, or both, happen when a closed fist hits a hard surface like a wall. The hand is swollen and tender, and X-rays are diagnostic. Treatment depends on the degree of angulation, displacement, or rotary malalignment. Closed reduction and ulnar gutter splint for the mild ones, Kirschner wire or plate fixation for the bad ones. Hip fractures typically happen to the old who sustain a fall. The hip hurts, and the patient's position in the stretcher is classic. The affected leg is shortened and externally rotated. Specific treatment depends on specific location as shown by X-rays. Femoral neck fractures, particularly if displaced, compromise the very tenuous blood supply of the femoral head. Faster healing and earlier mobilization can be achieved by replacing the femoral head with a prosthesis. Intertrochanteric fractures are less likely to lead to avascular necrosis and are usually treated with open reduction and internal fixation. The unavoidable immobilization that ensues poses a very high risk for deep venous thrombosis and pulmonary emboli, thus post-op anticoagulation is recommended. Femoral shaft fractures are often treated with intramedullary rod fixation. If bilateral and comminuted, they may produce enough internal blood loss to lead to shock. External fixation may help while the patient is stabilized. If they are open, they are an orthopedic emergency, requiring or cleaning and closure within 6 hours. If multiple, they may lead to the fat embolism syndrome. Knee injuries typically produce swelling of the knee. Knee pain without swelling is unlikely to be a serious knee injury. Swelling of the knee has been described as the poor man's MRI, a reference to its clinical reliability, and to the fact that MRI is the best highly technological way to look inside the knee. Collateral ligament injuries are usually sustained in a sideways blow to the knee, a common sports injury. Medial blows disrupt the lateral ligaments, and vice versa. The knee will be swollen and show localized pain by direct palpation on the affected side. With the knee flexed 30, passive abduction or adduction will produce pain on the torn ligaments and allow further displacement than the normal leg. Abduction demonstrates the medial injury's valgus stress test, whereas adduction diagnoses the lateral injury's varus stress test. Isolated injuries are treated with a hinged cast. When several ligaments are torn, surgical repair is preferred. Anterior cruciate ligament injuries are more common than posterior ones. There is severe knee swelling and pain. With the knee flexed 90, the leg can be pulled anteriorly, like a drawer being opened. Anterior drawer test. A similar finding can be elicited with the knee flexed at 20 by grasping the thigh with one hand, and pulling the leg with the other. Lockman test. Posterior cruciate ligament injuries produce the opposite findings. MRIs are diagnostic. Sedentary patients may be treated with immobilization and rehabilitation, whereas athletes require surgical reconstruction. Almost all cruciate injuries are sports-related and require surgery. Meniscal tears are difficult to diagnose clinically and on X-rays, but are beautifully shown on MRI. Patients often have protracted pain and swelling after a knee injury, and they may describe catching and locking that limit knee motion, and a click when the knee is forcefully extended. Repairs done, trying to save as much meniscus as possible. Complete meniscectomy leads to late development of degenerative arthritis. Injuries to the medial meniscus, the medial collateral, and the anterior cruciate often occur simultaneously. Tibial stress fractures are seen in young men subjected to forced marches. There is tenderness to palpation over a very specific point on the bone, but X-rays are initially normal. Treat with a cast and repeat the X-rays in 2 weeks. Non-weight-bearing crutches is another option. Leg fractures involving the tibia and fibula are often seen when a pedestrian is hit by a car. Physical exam shows angulation. X-rays are diagnostic. Casting takes care of the ones that are easily reduced. Intramedullary nailing is needed for the ones that cannot be aligned. The lower leg along with the forearm is one of the most common locations for development of the compartment syndrome. Increasing pain after a long leg cast has been applied requires immediate removal of the cast and appropriate assessment. Rupture of the Achilles tendon is seen in out-of-shape middle-aged men who subject themselves to severe strain. Tennis, for instance. As they plant the foot and change direction, a loud popping noise is heard like a rifle shot, and they fall clutching the ankle. Limited plantar flexion is still possible, but pain, swelling, and limping bring them to the doctor. Palpation of the tendon reveals a gap. Casting in equinus position allows healing in several months. Surgery achieves quicker cure. Fractures of the ankle occur when falling on an inverted or verted foot. In neither case, both malleoli break. AP, lateral, and mortise X-rays are diagnostic. Open reduction and internal fixation is needed if the fragments are displaced. Orthopedic emergencies. The compartment syndrome occurs most frequently in the forearm or lower leg. Precipitating events include prolonged ischemia followed by reperfusion, crushing injuries, or other types of trauma. In the lower leg, by far the most common cause is a fracture with closed reduction. The patient has pain and limited use of the extremity. The compartment feels very tight and tender to palpation. The most reliable physical finding is excruciating pain with passive extension. Pulses may be normal. Emergency fasciotomy is required for treatment. Pain under a cast is always handled by removing the cast and examining the limb. Open fractures, the broken bones sticking out through a wound, require cleaning in the or and suitable reduction within 6 hours from the time of the injury. Posterior dislocation of the hip occurs when the femur is driven backward, such as in a head-on car collision where the knees hit the dashboard. The patient has hip pain and lies in the stretcher with the leg shortened, adducted, and internally rotated. In a broken hip, the leg is also shortened, but it is externally rotated. Because of the tenuous blood supply of the femoral head, emergency reduction is needed to avoid avascular necrosis. Gas gangrene occurs with deep, penetrating, dirty wound stepping on a rusty nail, with lots of mud or manure. In about 3 days the patient is extremely sick, looking toxic and moribund. The affected site is tender, swollen, discolored, and has gas crepitation. Treatment includes penicillin and clindamycin, extensive emergency surgical debridement, and hyperbaric oxygen. Other galloping soft tissue infections are seen primarily in immunocompromised patients, diabetics, AIDS patients, the most common being synergistic bacterial gangrene and necrotizing fasciitis. Patients debilitated by extensive burns or widespread trauma may suffer fulminating fungal infections. The most feared of these is mucormycosis, in which the affected area is turned black. Diagnosis is confirmed by tissue biopsy. All of these conditions require repeated, massive surgical excisions of dead tissue in addition to appropriate antibiotics. Broad spectrum for synergistic bacterial gangrene and necrotizing fasciitis, for amphotericin B for mucormycosis. Associated neurovascular injuries. The radial nerve can be injured in oblique fractures of the middle to distal thirds of the humerus. If the patient comes in unable to dorsiflex, extend the wrist and regains function when the fracture is reduced and the arm is placed on a hanging cast or coaptation sling, no surgical exploration is needed. However, if nerve paralysis develops or remains after reduction, the nerve is entrapped and surgery has to be done. Popliteal artery injuries can occur and posterior dislocations of the knee. Attention to the integrity of pulses, Doppler studies, or CT angio, are key issues. Prompt reduction will minimize vascular compromise. Delayed restoration of flow requires prophylactic fasciotomy. Injury patterns. The second, hidden fracture. The direction of force that produces an obvious injury may produce another one that is less obvious and needs to be sought. Falls from a high landing on the feet may have obvious foot or leg fractures. Fractures of the lumbar or thoracic spine may be less obvious, and must be looked for. Head-on automobile collisions may produce obvious injuries in the face, head, and torso, but if the knees hit the dashboard, the femoral heads may be driven backward into the pelvis or out of the acetabulum. Facial fractures and closed head injuries should always prompt evaluation of the cervical spine. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed. Wishes. Dr. Atef Ahmed. Wishes.